morning, ladies and gentlemen. Let me start by firstly thanking the President and Council of MATCVS for this very kind and thoughtful gesture to inaugurate this memorial lecture in memory of our dear colleague and friend, the late Mr. Balaji. As many of you will know or remember, Mr. Bala, probably best remembered as a highly accomplished thoracic surgeon. And I would say that perhaps his most productive, his most prolific years were spent in Serdang Hospital. So it's most apt that this memorial lecture has been incorporated as part of a thoracic symposium and at this 25th annual scientific meeting of MATCVS, which is being very wonderfully hosted by Hospital Serdang. And I do hope that this memorial lecture will be a regular feature in future scientific meetings in the years to come. Regrettably, his immediate family is currently overseas and they are unable to attend today, but I can assure you they are immensely grateful and touched by this very kind gesture by the society. So as Prof Soon has mentioned, for me it's a distinct honor and privilege to present this first ever B. Balaji Memorial Lecture, and the topic of my lecture is to present From Vision to Reality, the first non-small cell lung cancer guidelines for Malaysia. So what we have here is essentially guidelines that have been developed by a group of surgeons, and I will elaborate as we go along. Essentially, these are clinical practice guidelines for early stage resectable non-small cell lung cancer, and we cover the whole gamut from screening through to diagnosis and staging, the perioperative management, neoadjuvant, intraoperative, adjuvant, as well as post-resection surveillance and operative metrics. I'm happy to share that these guidelines have been endorsed by all the major relevant national societies, the Malaysian Oncological Society, the Malaysian Thoracic Society, the College of Surgeons within the Academy of Medicine Malaysia, and of course our own MATCVS. It has been recently published in a reputable journal, Translational Lung Cancer Research, which is the official journal of the Hong Kong Society and endorsed by the Brazilian and Spanish societies as well. In essence, we have, and I will share with you shortly, a total of 21 key recommendation statements across 5 sections, underpinned by 166 contemporary up-to-date references. But this is not just a collection of scientific evidence, but it incorporates real-world local expert opinion and real-world practice. So it's unique and hopefully practicable for use here in Malaysia. So in essence, it is to elevate and harmonize the real-world perioperative care that we offer our patients. So we take a step back. Why the need for guidelines? Well, you know, a couple of years ago when I was the president of Lung Cancer Network Malaysia, I first mooted the idea for our own local guidelines, and I can share with you there was considerable pushback, mainly from the oncologists in our group, who quite rightly said, look, we have international guidelines, we've got NICE, we've got NCCN, ACCP. They felt this was going to be a very onerous task, which it was, and that perhaps it was unnecessary. But I felt very strongly there was a need for us to have local guidelines pertinent to Malaysia or Asia, because as you will all know, the tumor biology and the patient demographics are quite different here in Malaysia and Asia compared to the West. So a few years later, we revisited this idea and delighted that a group of my colleagues in surgery agreed, and we proceeded to develop these guidelines. The other reason to have guidelines is, as you will all appreciate, you know, the treatment paradigm for early stage resectable non-small cell lung cancer has evolved considerably in recent years, reflecting tremendous advances in the diagnostic and treatment landscape. And therefore, for any surgeon, practicing surgeon or future aspiring surgeon who plans to perform resections for lung cancer, it is imperative that we keep abreast of these developments, and these guidelines reflect that, and naturally will require regular revision and updating. The practice of lung cancer surgery in Malaysia is quite diverse. You know, the resections are performed by cardiothoracic surgeons, like members of our society, as well as general thoracic surgeons. And some surgeons ply their trade in the university hospitals, some in the Ministry of Health government hospitals, and some in the private sector, and perhaps some across all three arms of the healthcare sector. And we recognize that there can be differences in the provision of services, hopefully not so much in terms of quality, but in terms of the timeliness. And therefore, we felt there was a need to harmonize the provision of care. It shouldn't matter where a patient accesses treatment and by whom. Malaysians should be assured of high-quality, timely care for lung cancer. We also envision these guidelines to be a useful training and teaching tool for existing surgeons and aspiring specialists. And on a practical level, for those of you who work in the private sector, you will empathize that we are often inundated with quite frivolous queries from the insurance companies, querying why the need for a bronchoscopy, why the need for lymph node sampling. So I think it's important and useful to have a local document, a robust document that we can fall back on. So as I mentioned, the treatment paradigm for early stage resectable disease has evolved considerably. What's important is we recognize that both the patient journey and the MDT practice is evolving. And therefore, I want to use this opportunity to reiterate to the surgeons in the audience that we need to be involved in patient care right from the start of the patient journey. And this means you need to have the knowledge and stay abreast of the latest developments. There's tremendous advances that are happening in terms of the treatments, the multimodal approach for lung cancer. And we need to be present, make time in our daily schedule to attend tumor board meetings. Again, this just reflects a similar increasingly complex and rapidly evolving treatment paradigm. Here I just want to emphasize the importance of tumor biology, which is now almost as important as the stage of disease to dictate the treatment paradigm as you move the patient along. So I'm going to share the guidelines, but in essence, it is a consensus document. It's a CPG. It is very concise. We have been very focused in that it addresses resectable non-small cell lung cancer. So by definition, stage 1 through to highly selected cases of stage 3B, N2 disease. It does not address small cell or any other neuroendocrine tumors. We don't deal with metastatic secondary cancer or other aspects, airway tumors. And also, we mentioned briefly, but we don't cover in depth, for example, the non-surgical management of early stage disease in the medically inoperable patient, i.e. SBRT ablation. It has a multidisciplinary flavor. I'm happy to say that we had review from 2 very eminent oncologists and 2 pulmonologists to make sure that these guidelines are fit for real-world use. And the working group that I will share with you shortly is very representative, which I felt was important, this diversity to reflect what real-world practice is in Malaysia. So how did we go about establishing the guidelines? Well, a logical starting point is we reviewed the existing literature, the existing guidelines, and then we adapted what we felt was salient features for Malaysian, Asian, and particularly Malaysian landscape. As a template, we used the North American AATS, American Association for Thoracic Surgery guidelines, but we made considerable advances on this, adding extra domains on screening and post-resection surveillance, as well as updating the latest scientific data. And we adopted the modified Delphi method using a Likert scale. The end result is an evidence-based, consensus-driven CPG, which is fit for real-world daily clinical practice. So at this point, it gives me pleasure to just, this is a team effort, collaboration, and you can see from the diversity of the surgeons involved in the working group that we have cardiothoracic surgeons and general thoracic surgeons working in the private sector, in the universities, and in the Ministry of Health, working in Peninsula and East Malaysia. And we felt this was very important to be able to reflect real-world practice across different arms of the healthcare sector and in different parts of the country. And also I want to acknowledge the external reviewers, one of whom is here, Dr. Voon, who's taking a photo as we speak, kindly gave their time to review the document very meticulously, the others being Professor Liam, Prof. Pang, and Dr. Tho, to ensure that these guidelines, as I said, are practicable, pragmatic, and feasible for daily use. So that said, let me share with you some, in the interest of time, some of the key salient. I won't go through all the recommendations. I will just pick out a few key recommendations from each section of the CPG. So section 1 deals with screening, and we felt it was important to recognize the growing phenomenon of lung cancer in the non-smoker or never smoker, which is comparatively higher here, the prevalence compared to the West. And if we were to rigidly adhere to Western-derived screening criteria based on a tobacco smoking history, then we will fail to address this unmet need to capture lung cancer early in the non-smoker or the never smoker, the majority of whom are women. And so one of the recommendations is that screening should be offered to the high-risk non-smoker or never smoker, whom we have defined as someone over the age of 40 with a family, a significant family history of lung cancer, which we have defined as, having a first-degree relative, like a sibling. Now, I'm a big proponent for AI and trying to triage using chest X-rays to triage for lung cancer, but at the present time, the standard of care for imaging is still with a low-dose CT scan, but we hope AI will enhance chest X-ray imaging and biomarkers to pick up the disease earlier. With regards to diagnosis and staging, you will see point 2, we feel very strongly that any patient, once they have histological confirmation and have been appropriately staged to have early stage resectable disease, it is very important that treatment is initiated within a window of 4 to 6 weeks. And the consensus of the expert group was this is very feasible irrespective of where you practice, if it is prioritized. There is a lot of evidence out there that the time to treatment initiation impacts significantly on outcomes in terms of survival and recurrence-free survival, particularly for early stage disease. And in the case of resectable disease, that is either going to be upfront surgery or some form of neoadjuvant chemoimmunotherapy. Equally important is point 3 in this new era of biomarker-driven treatments, that we establish early on at the start of the patient journey the tumor biology. So if there's adequate tissue from the initial biopsy, we advocate in these guidelines that a reflex testing should be done for genomic molecular profiling. Reflex testing means that the pathologist is empowered to proceed with the genomic testing, the NGS testing, and this will shorten the turnaround time rather than to refer back to the referring physician or surgeon. And as a minimum, we need to test for EGFR, ALK, and PD-L1, and we recommend this for stage 2 and above, because in stage 1, you're not going to offer any neoadjuvant treatment, irrespective of the tumor biology. Section 3, very important, particularly for the surgeons here. Stage 3 disease. All clinical stage 3 should be discussed in a multidisciplinary tumor board to be considered for neoadjuvant treatment. We don't want surgeons operating on stage 3 without prior discussion, no more than we want an oncologist or pulmonologist to commence systemic treatment without discussing with the surgeon. However, we felt strongly that many cases of stage 2 resectable disease may be amenable to upfront surgery first. This has been the standard of care for a long time. And unless there is a surgical concern with achieving a complete R0 resection through a lobectomy or a lesser resection. Just to highlight here that the importance of the surgeon, I use the term thoracic surgeon, whether it's a general thoracic, a cardiothoracic, the surgeon performing the resection. The surgeon, and only a surgeon, can evaluate resectability, and that has to be done prior to any treatment initiation, institution of any systemic therapy. Our guidelines align with the global guidelines, the IASLC, which concede that there is no consensus for stage 2 disease. There is no robust head-to-head comparison or randomized data whether you should cut first and then give adjuvant or whether you should offer neoadjuvant. So we have to be very judicious and factor in real-world considerations of cost, toxicity, surgical attrition, those that don't proceed to surgery, and of course, patient preference. So this just reiterates what I've said, that the current evidence does not conclusively support the superiority of any one therapeutic approach. And I think outside the setting of a clinical trial for stage 2 disease, we have to proceed with caution. Section 4 deals with adjuvant. We recommend that all patients following curative resection, stage 1B and above, should be seen by an oncologist or a treating pulmonologist within 4 weeks of surgery. And given that most patients these days have minimally invasive surgery, the vast majority can avail of adjuvant treatment within 2 to 4 weeks. Equally important, I think you'll all be familiar with the ADAURA and the ELINA data. Certainly, if you have resected EGFR mutant or ALK mutant, then the evidence is very compelling for adjuvant osimertinib and alectinib, respectively. For the non-oncogene-driven non-small cell lung cancer, we feel it's very reasonable to be considered for adjuvant immunotherapy if they haven't had it prior to surgery, if there's no sensitizing mutation, and you have a PD-L1 expression of at least 1%. Finally, Section 5, and given that this is a surgical meeting and these are surgical guidelines, complete resection, a minimally invasive approach is probably favored and non-inferior, but the key point here is it's a cancer operation. You need to achieve a R0 complete resection. And of course, the adoption will depend on the individual surgeon's experience and comfort level. At the present time, a lobectomy remains the standard of care in a medically fit patient with early stage disease. Having said that, I think we all recognize there are a cohort of patients, those with small peripheral tumors, less than 2 centimeters in the outer third of the lung, and who are node negative. Either you establish that pre-surgery from EBUS or EUS, or intraoperatively with nodal sampling. These patients, it may be reasonable to offer them a sublobar resection, either an anatomical segmentectomy or a non-anatomical generous wedge. And this is also a reasonable strategy in the high-risk patient with borderline heart and lung function and significant comorbidities. I also want to reiterate the importance when we talk about a complete resection. It is more than just resecting the primary tumor with clear margins, although that is the single most important determinant of outcome. It is imperative that the surgeons conduct a good operation with concurrent systematic mediastinal lymph node sampling. And here we align with the American guidelines. This includes sampling at least 3 N2 stations and 1 N1 station. And finally, statement 5, just to highlight that all patients should have a minimum of 5 years post-resection surveillance. Some of it is stage dependent, but generally even for early stage, it should be every 6 months for the first 2 to 3 years, and then annually for a minimum of another 2 years. It doesn't matter whether the patient is followed up by the surgeon, oncologist, or pulmonologist, or perhaps often by all three, but we must ensure these patients remain under meticulous surveillance. So in conclusion, ladies and gentlemen, I just want to run through briefly the key recommendations in our first national CPG for lung cancer. We advocate for screening of the high-risk non-smoker or never smoker, someone with a family history, first-degree relative siblings. We advocate for early treatment initiation upon histological confirmation and appropriate staging. That window of 4 to 6 weeks is highly achievable, and it should be prioritized because we know it impacts on outcomes. Upfront reflex testing at the start of the patient journey, genomic molecular profiling, because we are now practicing in an era of biomarker-driven treatments. We need to know the tumor biology, who are the patients we can offer immunotherapy, who are the patients better served with adjuvant TKI, and so forth. All stage 3 should be discussed in a tumor board, and some of the borderline stage 2. But many cases of stage 2 still amenable to upfront resection. But for the surgeons in the audience, again, a good operation entails not just resecting the tumor, but lymph node dissection. Now, these conclusions are the same. Finally, I just want to end by acknowledging and thanking once again the presidents and the excos of the respective societies, the MTS, the MOS, our own MATCVS, the College of Surgeons, and the Academy, for their very enthusiastic and robust endorsement of our guidelines. This was a project undertaken by Lung Cancer Network Malaysia, and I also want to acknowledge the support that we received from AstraZeneca, who doubled up as the secretariat. And as you can see, I've mentioned there that they did not participate in any manner in the preparation of the guidelines per se or in the intellectual discussions. So on that note, I thank you for your kind attention.